right, go ahead and state your name.
This is Dr. Hillel Tobias.
And whenever you're ready.
Good evening. This evening we are going to talk about primary biliary cholangitis, formerly known as primary biliary cirrhosis, and we're going to discuss the diagnosis and treatment options available today. Primary biliary cholangitis, as it's now called, or PBC to the folks, chronic cholestatic liver disease, which is autoimmune in nature, is characterized by inflammation and destruction of small interlobular bile ducts. It affects predominantly middle-aged women. It has a rising incidence and prevalence in society and our country today. How does one diagnose PBC? Well, the understanding is that you have to have 2 out of the 3 criteria required for the diagnosis of PBC. 1 is an unexplained elevation of the alkaline phosphatase greater than 1.5 times normal. 2 is a positive antimitochondrial antibody. And 3 is histology, a liver biopsy that shows non-suppurative destructive cholangitis on histology. You only require 2 of these 3 criteria, and you can notice that you can diagnose this without the antimitochondrial antibody. There are variant syndromes associated with primary biliary cholangitis. There is, as I mentioned, the AMA negative PBC. 50% of these people will have anti-nuclear antibodies, and they may even have PBC-specific antibodies to ANA with anti-GP210 and anti-SP100. They have usually the same clinical presentation. They may have a reduced survival. Also associated with PBC is the so-called overlap syndrome, which incorporates an element of autoimmune hepatitis. Consider this when the alkaline phosphatase transaminase ratio is less than 1.5, when there is a significant elevation of the IgG as well as the IgM that is notable in PBC, and the presence of smooth muscle antibodies in titers greater than 1:80. A third variant is a patient who has premature ductopenic variation. This occurs in about 5 to 10% of patients. A very rapid onset of ductopenia with severe icteric cholestasis and fast progression towards cirrhosis. How does the PBC patient present clinically? 60 to 70% of these patients will be asymptomatic. Most will eventually become symptomatic. Those that are symptomatic may present with pruritus, fatigue, or the Sika syndrome. Only 5 to 10% of patients presenting for the first time actually have cirrhosis, and portal hypertension may occur in the patients with cirrhosis as well as in some minority of patients who do not yet have cirrhosis. In dealing with PBC, there is the diagram shown on the current slide of how one manages the situation. I don't know if it's necessary to go through every single little box, but basically you do a baseline evaluation, and which includes an imaging study, evaluation of the symptoms, and of the laboratory studies, and possibly a liver biopsy to try and evaluate the stage of the disease. The patient may have fatigue, may have pruritus, may have a Sika syndrome, or may have none of those. Once you have made the diagnosis, the standard therapy is initiated with ursodeoxycholic acid, 13 to 15 milligrams per kilogram per day. And then there's a long-term follow-up. Actually, there's clinical evaluation on a periodic basis. There's imaging studies on a periodic basis. And nowadays we can use transient elastography to see how much fibrosis is present and how it is progressing. If the patient progresses to the stage of cirrhosis, then we need to surveillance imaging be instituted to determine whether they have hepatocellular carcinoma, whether they have esophageal varices on endoscopy, and whether they need an additional therapy because they are not responding adequately to the ursodeoxycholic acid. Yes, UDCA or URSO is the first line defense, or actually the first line treatment for this syndrome. It's an orally administered, naturally occurring hydrophilic secondary bile acid. The usual dose is 13 to 15 milligrams per kilogram per day. Improvement in liver tests may be seen within a few weeks, and 90% of the improvement usually occurs within the first 6 to 9 months. After 1 year of treatment, the number of patients with biochemical response, according to various criteria, is usually around 65%, 62%, 66%. It is noted that up to 40% of people treated with ursodeoxycholic acid may have a suboptimal response and may be in need of further therapy. What are the therapeutic effects of UDCA? Well, they're shown on this little diagram. You can get improvement in liver enzymes, you get improvement in cholesterol, you get improvement in survival, delay in the development of cirrhosis, and delay in any histologic progression. Usually one follows the patients by following the serum liver enzyme test, and that will give you a good idea of where they are going. There are various ways of scoring the progression of PBC. The global scoring system, I don't know that the particulars are really necessary, but it basically is an indication by evaluating the age of the initiation, the total bilirubin, the alkaline phosphatase, the albumin, and the platelets, which are standard things that we all follow in any case. Now, in case the patient does not respond to ursodeoxycholic acid, that is when we have to employ the new agent just recently approved, the FXR agonist. This FXR agonist of obeticholic acid is a derivative of bile acids. It causes bile acid homeostasis, or it works on bile acid homeostasis. It decreases the bile acid synthesis. It decreases bile acid uptake. It decreases bile acid absorption, and it increases bile acid secretion. That induces a choleresis, which leads to improvement in the patient's primary biliary cholangitis. It also has an anti-inflammatory effect with downregulation of various cytokines, TNF, etc. The effectiveness of this medicine was demonstrated in a landmark study called the POISE study, the POISE study design, which basically consisted of treating the patients with either placebo, 10 milligrams, 5 milligrams, or titrating them up from 5 milligrams to 10 milligrams. You can see from this bar graph here, in which obeticholic acid 10 milligrams is represented by the blue, and obeticholic acid 5 to 10 by the other color, whatever you want to call it. And the clear bar is the placebo study. It's obvious from just looking at this, just eyeballing this, that the patients treated with obeticholic acid, either in the 5 to 10 or the 10 milligram doses, did significantly better than, very significantly better than patients who were followed with placebo. In terms of adverse effects from the obeticholic acid, one is pruritus, one is nasopharyngitis, headaches, fatigue, nausea, and some of the other types of things that you see with many different medicines. The pruritus is maybe a bit of a problem, since it's maybe part of what is affecting the patient to begin with. However, in further observations, the pruritus seems to abate as the medication is continued. Overall findings of this study, the effect of obeticholic acid was consistent, independent of age, the diagnosis, duration of PBC, and the baseline alkaline phosphatase. Titration from 5 to 10 milligram based on clinical response, improved tolerance, minimized dropout due to pruritus, and showed comparable efficacy to 10 milligrams of obeticholic acid after a year. Thus, starting patients on 5 with titration to 10 based on the clinical response appears to be an appropriate dosing strategy. Obeticholic acid given to individuals with PBC with an inadequate response or unable to tolerate urso produced a significant clinically meaningful improvement in liver biochemistry, which has been shown to correlate strongly with clinical benefit. So the FDA-approved indication for obeticholic acid is the treatment of PBC in combination with ursodeoxycholic acid in adults with inadequate response to urso, or as a monotherapy in adults unable to tolerate ursodeoxycholic acid. In the long-term management of patients with PBC, in accordance with the ASLD guidelines, I think that's pretty obvious. You do liver enzyme tests every 3 to 6 months. We usually do them 3 times a year, every 4 months. Since there may be associated thyroid abnormalities with PBC, the thyroid tests are included in the regular liver enzyme and blood monitoring. There's an increased incidence of osteoporosis in these patients, so DEXA scans should be done every 2 to 4 years. There may be deficiency in fat-soluble vitamins, and they should be monitored. If the patient develops cirrhosis, the patient would require endoscopy every 1 to 3 years. And if the patient has a significant lowering the platelet count, endoscopy should be considered as well. Ultrasound plus or minus AFP should be done at least every 6 months in the patients who have established cirrhosis or are suspected of having cirrhosis to rule out HCC. There's no more slides.
Oh. Well, go ahead and say thank you for just a finishing line for whatever you want to say.
Well, thank you for allowing me to demonstrate for you the effectiveness of this new medication of obeticholic acid in the management of primary biliary cholangitis. I think it was an essential need for that group of patients who do not respond to the standard therapy, and we look forward to seeing over the years some improvement in longevity in these patients.
Okay. And